Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 9J, which is Cytopathology. We are streaming live from JIPMER, Puducherry via Kolkata. We have a very important topic and two very eminent people here today, the presenter as well as the moderator. The topic of the day is slide seminar on Serous Effusion. It's a case-oriented teaching. I would like to introduce the moderator, and the moderator, sir, will introduce the speaker. So the moderator of today is Dr. Bidut Krishna Goswami. He's an MBBS, MD, professor and head Department of Pathology, North Bengal Medical College. He's also the president of the West Bengal Cytological Society. He's also the life member of IMA, IAC, IAPM, IPHA, ACH. He's also next professor of NRS Medical College. He's the nodal officer for Thalassemia Control Unit at NBMC Darjeeling, director Central Laboratory North Bengal Medical College, technical director Regional Blood Transfusion Center. He's also as a guide and educator for MD Pathology PG exams. He's a member of various boards, and he's a very famous person nationally as well as internationally. I would request Dr. Bidut Goswami, sir, please introduce the speaker and we will start from there.
Thank you so much, Dr. Nadia. As you all know, we are passing through one devastation of century, that is COVID pandemic, and in fact another devastation just going on, and I should be very grateful to the organizer and to you as well to give me scope to introduce Dr. Siddaraju. We know body fluid cycle is very old, but an important diagnostic for various malignant and benign conditions. Diverse etiology like inflammatory infectious, benign maybe neoplastic or malignant, maybe primary or metastatic disease. In all this Serous Effusion helps us like anything. Sometimes overlapping features, sometimes different makers definitely made us feel confusion. The cytological interpretation of individual cells are paramount important to us here. Yes, sometimes it plays more important role than in some cases as well. Particularly in this era of serology with the ancillary studies, the Serous Effusion study has become very important. And it is very inexpensive, less invasive. I feel honored to introduce Professor N Siddaraju, one of my best friends in fraternity in this online DTL who has enormous experience in all facets of pathology. He, right at this moment, is the professor of pathology in JIPMER, world famous institute at Puducherry. Worked as also in MAMC, New Delhi. He is one MD and PhD guide for years. Field of interest is in cytopathology. Participated in various national and international conferences. Plenty of publications, papers, contribution. He served as an executive committee member in IAC. He is also an editorial board member in the Journal of Cytology, reviewers of various national and international journals. So with all this, I would request Dr. Siddaraju. In fact, I also let you know that in our last CME from our state chapter 2020 online CME, he also gave us support to have enormous knowledge in this session. So today we are going to get other pieces from his side. So Professor Siddaraju, please start. Thank you so much.
Okay, sir. Thank you so much for your kind words, sir. And at the outset, let me thank both Dr. Nadeem and you for having given me this opportunity and for those kind words. I'll start with my slide seminar. So, I'll be having I have some 16 cases, so I'll try to go as fast as possible, but stressing wherever stress is needed, I will try to slow down. Okay. Serous effusions
So just
can be
press
associated.
the present now and share your screen, sir. Just press present now, your entire screen.
It is there. It's already.
No, sir, it's not. Just try it once again so that it gets shared. And just press the center of the screen and press share.
Okay, okay, sir. Okay, sir. Share.
Just press the center of the screen and press share, sir.
This one.
Take your time, sir. Just press present now, your entire screen, and press the center of the screen and then press share. Excellent, sir. It's there. Now just share, just open your PowerPoint, sir, from the taskbar. Yes, sir. Please make it full screen, sir.
Okay, sir. Is it visible now, sir?
Absolutely, sir. Please.
Okay, I'll be starting my
there is no time limit. You can go at your pace, sir. Aram se.
Okay, sir. Okay, sir. I'll start now. Serous effusions can result from both benign as well as malignant conditions, and there are numerous benign conditions. I may not have to go into the details of that. I'll be stressing more on the malignant effusions only. And these malignant effusions can result from either primary tumors of the serous body cavities, or it can result from metastasis from elsewhere. And the primary tumors of the serous body cavities involve the mesotheliomas. These include mesotheliomas and very rare primary effusion lymphomas and not so infrequent primary peritoneal carcinomatosis. Whereas more common ones are the metastatic deposits only. The serous body cavities are more frequently affected by the metastatic tumors, and most of these metastatic tumors are adenocarcinomas, usually of lung, breast, ovaries, gastrointestinal tract, or pancreaticobiliary origin. These are more common ones, but virtually any malignancy can involve the serous body cavities with its metastatic deposits, and we can the serous body cavities can be involved even by certain non-epithelial neoplasms like hematolymphoid neoplasms, which are relatively common, and sarcomas can also involve, but rare, and other rare conditions like melanomas and even germ cell tumors and all those things can involve the serous body cavities. And all of us know that detecting malignant cells in serous effusions is of critical importance, because once you detect malignant cells, naturally it indicates upstaging of the disease. So before going into examination of the smears, we need to give attention to certain critical and essential details. First of all, we need to have the relevant clinico-radiological details of the cases. And whenever we receive the specimen, we need to examine the naked appearance of the samples, because that itself, at that level itself, at naked eye examination level itself, sometimes you can get the clues some clues of the underlying etiology, in fact, actually. And processing of samples, we need to take utmost care while processing the samples, in fact, actually. And I will not go into the details of that, because I have lots of cases. So I will just briefly give this introduction and proceed with my slide seminar. And one pathologist, whoever is reporting, should be aware of the obvious as well as subtle cytomorphological details of various lesions and the obvious and subtle cytomorphological difference among various mimics also. And one should be aware of even the common malignancies that are encountered in the routine practice. Because all these details, if we are aware, it makes our job easier by interpreting the cytological preparations. So I'm showing some malignant cells here, in fact, actually, and I don't think anybody will have difficulty in identifying these as malignant cells. But these are obvious malignant cells. There is so much of pleomorphism. These are the features of malignant cells, and some of these like this. So much of pleomorphism, marked pleomorphism. You can see this vesicular, prominent nucleoli, and very glandular pattern you can see. Here, more glandular patterns you can see, in fact, actually, and here also glandular pattern, vacuolated cells. These are indicative of adenocarcinoma, papillary pattern, again indicative of papillary adenocarcinoma, and certain other individual cellular features like tumor cannibalism, a malignant cells engulfing another malignant cell, and mitosis, abnormal mitosis, and certain architectural pattern like these globular clusters are what are referred to as proliferation spheres. Sometimes these kind of architectural features can suggest the possible primary site as well. That's the reason we need to be aware of these things. And the background, here there is so much of mucin in the background, and more of individual cells, dispersed cell population of these signature cells. Again, these kind of morphological features also will give clues to the underlying cause, underlying precise type of malignancy. And sometimes you can get malignant cells can have this ciliary tufts, which is a rare finding, which is described in certain tumors like ovarian adenocarcinomas and sometimes in mesotheliomas. So if you are aware of these features, it becomes easier for us to interpret easily and avoid errors. And with this slide, I just want to tell you, there are certain features which are said to be quite specific for mesothelial cells. I have shown two features that are said to be somewhat specific for mesothelial cells. One is this, the presence of prominent windows, and here some sort of knobby contour, and even some windows also you can see, in fact, actually. These are said to be characteristic features of mesothelial cells. But these are not mesothelial cells. What I want to stress with these pictures is that we cannot go by just one cytomorphological or cytoarchitectural pattern. We need to have a constellation of individual cytomorphological features and architectural features in order to decide whether a case is malignant or benign. These are obviously malignant. How to decide that? There is so much of pleomorphism and some degree of nuclear overlapping you can make out. So much of pleomorphism. Look at the chromatin pattern, it is coarse. Some degenerative change is there, but still this is coarse chromatin, hyperchromatic, and some prominent nucleoli also you can see, in fact, actually. Similarly, here also irregular nuclear membrane, all those features are very well made out, and no mesothelial cells will have this atypia. Okay, let us proceed with the cases. One by one, I will start presenting these cases, and I would be very happy if you can give your feedback. Case number one. This was a 27-year-old female patient and presented with pleural effusion. This much detail only was there, in fact, actually. And what is your opinion about this smear? It's a cellular smear which has both individual cells as well as clusters of cells. And these clusters are three-dimensional, and they are looking very dark, both the individual cells as well as the three-dimensional clusters of cells are looking very hypochromatic, and individually if you see these cells, you can make out a high NC ratio and irregular nuclear membrane. These features you can make out, in fact. Actually, certain other subtle details you may not be able to identify here. It's looking very dark, in fact, actually. But anyway, these clusters also, the cluster margin, look at the cluster margin, because this is one feature which is quite specific for malignancy. The clusters with smooth contour, all these three clusters, three-dimensional, and they're globular also. They're looking like spherules. They're looking like spherules with smooth contour. These are called proliferation spheres. I'll show you. So here again I have shown more such globular clusters, and the individual cellular features are somewhat better here. We can make out even the prominent nucleoli. Some clusters are loosely cohesive, but most of them are forming the proliferation spherule. So what is your diagnosis? What is a possible diagnosis? She is a 27-year female patient, and she has presented with pleural effusion. So what is the common possible diagnosis here in this? What is the most probable diagnosis? This was a case of invasive ductal carcinoma, and this is said to be one of the classic morphological feature in case of invasive ductal carcinoma presenting with effusions. And it may not be seen in all the cases, but when you see these proliferation spheres and a female patient presenting with pleural effusion, you should first think in terms of breast carcinoma. Try to rule out the possibility of breast carcinoma. Again, I'm going to say that this is not very specific, but this is most characteristic of the invasive ductal carcinoma of the breast, though it can be seen in other malignancies like ovarian malignancies, sometimes even in lung malignancy. For pulmonary adenocarcinomas, it can be seen, but it is more frequently encountered with the invasive ductal carcinoma of the breast. So this is what I wanted to tell you. Though it is not a very specific feature, but it is one of the strong morphological clue for diagnosing metastatic invasive ductal carcinoma of the breast in the pleural fluid. So further history was taken in this. This was a known case of infiltrating ductal carcinoma of the breast, and the patient had undergone mastectomy some 1.5 years back, and she had received even chemotherapy as well as radiotherapy. And if you have problem, if you are dealing with unknown primary, then if you want to confirm the diagnosis of the invasive duct, so morphologically you are suspecting and you want to confirm. So these are the markers which you can use. The GCD, PF15, mammoglobin, GATA3. Generally we use GATA3 here, and sometimes we can use these markers also, but these are more of prognostic significance rather than diagnostic significance. But these ones we generally try to use GATA3. Anyway, in this case that need was not there. And what are the other, is it possible to diagnose other malignancies of breast in the pleural fluid? Yes. The one more malignancy that can easily be detected when classic features are there is lobular carcinoma of the breast. In comparison to your invasive ductal carcinoma of the breast, this tends to present with dispersed population of cells, and sometimes you can get these cells arranged in a linear pattern, like Indian file pattern, what is described in histological sections. Sometimes that can also be seen, but mostly it is dispersed population. They are somewhat small to medium-sized cells with a high NC ratio, and this is a case of infiltrating ductal carcinoma, which is showing bullseye inclusions. These are just mucin-like spots within the intracytoplasmic lumina of a malignant cell. As such, you know that intracytoplasmic lumina is one of the characteristic feature of ductal carcinoma of the breast, and this can be seen. This is the intracytoplasmic lumina, whereas these bullseye inclusions are described both in invasive ductal carcinoma of the breast as well as in the lobular carcinoma of the breast. But the distribution of cells will be different in invasive ductal carcinoma of the breast and in the lobular carcinoma. Lobular carcinoma, this is how it is in small cells dispersed. You will see more of a scattered population of atypical cells. Coming to the next case, this was a 65-year-old female who presented with low-grade fever and breathlessness for 3 months. And she had dry cough, loss of weight and appetite for 2 months. And she also had bilateral pedal and periorbital edema for 2 months. And there is a history, in fact, actually. Breathlessness, mainly fever and breathlessness, not really indicating neoplastic pathology here. However, on examination, she also had right cervical lymph nodes, level 3, 2 and 4, which were firm, mobile, non-tender. The largest was measuring around 2 by 1 centimeter. Left parotid swelling, the patient also had left parotid swelling, measuring 3 by 3 centimeters, which was hard in consistency and was also fixed to the underlying structures. The clinical impression was not provided. The requisition did not carry the clinical impression, and radiological details were also not available at the time of the pleural fluid examination. And this patient was subjected to fine needle aspiration cytology of parotid as well as parotid gland as well as the lymph nodes. At the same time, pleural fluid was also sent for cytological examination. This is the pleural fluid smear we received. Very cellular, but it's almost sheets of these cells having somewhat atypical nuclei. It varies. Pleomorphism also varies, in fact, actually. One cell you can see with budding kind of thing, in fact, actually, but most of them, there are binucleated cells, multinucleated cells with variable sized nuclei, all these features, but it's all sheet-like pattern, almost looking like mesothelial cells, in fact, actually. Let us see. Here also, some are looking dispersed amidst a population of inflammatory cells, amidst a population of, but there is no clustering, but similar multinucleated cells, and there is pleomorphism. It's not very, at first glance it looks somewhat monomorphic, but it's not as monomorphic as it looks at first glance, in fact, actually. Let us see. This is the MGG stain smear. Same, you can see this dual zone also, like you get in the mesothelial cells. Similar pattern and sheet, but because it is arranged in sheets, almost looking like as if there are some windows also. But basically it has a sheet-like pattern, and in between you are getting inflammatory cells and these macrophages. Sheets of cells, same thing only. I'm showing more and more picture, in fact, actually. Look at this. Many of them look like mesothelial cells only. Many of them look like mesothelial cells. Again, you can, in this slide, pleomorphism is somewhat more appreciable as compared to the previous smears. Look at this. The pleomorphism has become even more. So it is not just reactive mesothelial cells. Not just reactive mesothelial cells, because these kind of features are unusual. If at all, if it is mesothelial cell, maybe you can think of mesothelium. Maybe you can think of mesothelioma. But it is not looking like reactive mesothelial cells. Let us see. So generally when we get a picture like this, in an Indian scenario, the incidence of mesothelioma is less. Otherwise, that is the reason why I would like to start with epithelial markers rather than the mesothelial markers. And clinically also, there was no evidence of any primary lung lesion. Mass lesion, but the patient had respiratory symptoms. So, taking that clue with some lymph node enlargement, we proceeded with, we wanted to rule out the possibility of bronchogenic adenocarcinoma first, bronchogenic carcinoma first. So we started with, because this morphology is not that of squamous cell. That is the reason I'm thinking more in terms of, I want to rule out an adenocarcinoma first, in fact, actually. Let me see. So NAPSIN A is very strongly positive. Nice cytoplasmic positivity you can make out, in fact, actually. See, the TTF1 is also very strongly positive. You can see this very strong nuclear expression. Now, strong nuclear expression of the neoplastic cells by this TTF1. This is a bit unusual. The pattern was a bit unusual. Because usually your adenocarcinomas, you will get some clusters and all that thing, vacuolated cytoplasm and all that thing. Those kind of features were not really evident in this. They were looking more like mesothelial cells, in fact, actually. But still, we proceeded with the epithelial markers first. Going by the presentation of the case, we wanted to rule out the bronchogenic carcinoma only first, and that itself has worked. So that we have saved the other markers. We didn't use a panel of markers. With taking clues from the clinical presentation, we have proceeded with the bronchogenic adenocarcinoma markers. This is a case of bronchogenic adenocarcinoma. And I said that this patient was subjected to FNAC also. Parotid FNAC was also showing similar feature, in fact, actually. That was what was interesting in this case, in fact, actually. Hardly there was any difference in the cytomorphological features of the parotid aspirate and the pleural fluid cytology. Similar features. Whatever I was showing there, it is seen in this also, in fact, actually. And here also, look at, but only thing, we were able to, this is a lymph node aspirate. Lymph node aspirate was showing both dispersed cells as well as these clusters of cells, and the most clusters had eccentrically placed nucleus and moderate to abundant cytoplasm, in fact, actually, and some sort of necrotic background was also there. And we did, because we wanted to rule out whether the metastatic deposit was from lung only. So we did that, and this was TTF1 was nicely positive, and this was metastasis from the lung itself. And chest examination, it's not really very clear, but showed massive left-sided pleural effusion and the growth in the right lung. So what was striking in this particular case was sheet-like arrangement of the mesothelial-like cells. Mesothelial-like cells. There were some features which were looking like mesothelial cells, but most of the cells did not have that dual zone. But there were cells that had dual zone of the endocytoplasmic zones also it had, in fact, actually. What are the cases that present with this kind of sheet-like pattern of neoplastic cells? One is the diffuse gastric adenocarcinoma, because by assessing the pattern and by assessing the individual cytomorphological features, it is often possible to, and in correlation with the clinical details, it is often possible to pinpoint at the primary site, in fact, actually. So diffuse gastric, but there are certain other features. The cells will be, cells from diffuse gastric adenocarcinomas will present like sheets or dispersed population of cells. And of course, hematolymphoid neoplasms are also known to present with a sheet-like pattern. And as I said, lobular carcinoma can also have dispersed cell population. Melanoma is also known to have a dispersed cell population, in fact, actually. And mesothelioma sometimes can have this kind of pattern. Of course, here, if at all, if there was any differential diagnosis, it was mesothelioma. But mesothelioma is not very common, and it is very common among very elderly individuals. Because for mesothelioma to develop, it needs very long period of exposure, in fact, actually. So I'm showing the examples of some malignancies that can present with the sheet-like pattern. This is one case, diffuse gastric adenocarcinoma, where the cells are looking almost like lymphoma, in fact, actually. But here are the cells that are telling that they are not lymphomas, they are not hematolymphoid cells, but epithelial cells. These are the cells that have eccentrically placed nucleus and mucin-filled cytoplasm. Look at this. these things. So individual cytomorphological features also you need to look into, in fact, actually. And this is one interesting case. We don't have the complete follow-up of this case, but still, here there are cells which resemble somewhat the cells which I showed there, but only difference is these ciliary tufts. Almost all the cells, all these mesothelial-like cells had the ciliary tufts, in fact, actually. Ciliary tufts. It was difficult for us to decide whether they are mesothelial cells or whether they are epithelial cells, in fact, actually. That too, in pleural fluid samples, the patient did not have any ascites also, because these kind of ciliary tufts sometimes can be seen in ovarian carcinoma, primarily with ascites, but this patient had primarily presented with pleural effusion, and again the DD will be like the metastatic carcinoma, metastatic adenocarcinoma from ovary or mesothelioma. Anyway, we did markers, 2 epithelial markers we have done. 2 epithelial markers, E-cadherin was also strongly positive, and even those ciliary tufts also had nicely taken the stain, in fact, actually. And EMA was also, epithelial membrane antigen was also nicely positive, indicating that these were all malignant epithelial cells, but not mesothelial cells. But only thing, I don't know the precise primary site in this case, because we don't have the complete follow-up of this case. But just I am showing a case of malignancy that has presented with sheet-like pattern of malignant cells. This is hematolymphoid sheet-like either on the markers are done on smears, but it can be done in the cell blocker, so that is even more convenient. This I learned parotid metastasis from primary pulmonary adenocarcinoma A state. That is what I wanted to say. And the highlights of this case was that it had an unusual morphology with sheet-like pattern with a striking striking morphologic resemblance to mesothelial cells, and these cells were seen both in FNA material as well as pleural fluid cytology. And the primary pulmonary adenocarcinoma was also unsuspected here, and the diagnosis was established primarily by cytology, and cytology has such a strong role. If your approach is good, then you can arrive at the precise diagnosis at cytology level itself, in fact, actually. And parotid metastasis, one more point I wanted to stress in this case is parotid metastasis from pulmonary adenocarcinoma is uncommon. So usually the adenocarcinomas from lung will present like this. This is a different case I am showing, actually, because what we saw is an unusual pattern, somewhat an unusual pattern, but usually we see like this, that you can get some glandular clusters, many malignant cell clusters with vacuolated cytoplasm. This is on cell block. Even sometimes you can get mucinous material also, but it will be difficult with this morphology to precisely say from where exactly it has metastasized. But this is the usual type of features you will see. Usual features of adenocarcinoma you will see from lung, and of course we have demonstrated with the uncell block section with CK7 and TTF1 positivity. Case number 3, a 65-year female patient who presented with history of breathlessness and pleural fluid cytology was sent to us. This was the picture, in fact, actually. It was a cellular smear. There were many clusters in a hemorrhagic background, very cohesive, in fact. Actually, most of these cells had very high NC ratio, and in fact, you can see even here the nuclear molding, very nice nuclear molding you can see. And at this stage, because this is higher magnification only, individual cells also, you cannot make out any nucleolus or anything like that. Again, there is a caterpillar like cluster, caterpillar-like cluster. Here again, some nuclear molding you can see. Again, nuclear molding. Say that this is, we could have say AUS or something like that, but we called it follicular variant of papillary thyroid carcinoma based on the combined feature, after combining the features of fine-needle aspiration, the nuclear inclusion. Only thing there is some unusual feature here, the fire flares. Generally we don't get them, but rarely it is described even in neoplastic lesions. Subsequently we received the pleural fluid. Pleural fluid was not very cellular, but it had these kind of clusters, which were very unusual kind of morphological features, in fact, actually, with unusual kind of morphological features. It looks like microfollicle here, filled with something in the lumen, and monomorphic cells, in fact, actually. We had a doubt whether it could be, because they had mentioned that history also, but usually your follicular variant or the conventional variant of papillary carcinoma doesn't behave so badly, but its behavior sometimes can be erratic. Anyway, further workup we couldn't do. We commented about this atypical cells and sent it. We did not report it as positive for malignant cells, but subsequently the pleural biopsy was also taken. That was reported as metastatic papillary carcinoma. So it is very rare actually for papillary thyroid carcinoma to manifest with the pleural effusion. This is one such case, and this is one of our recent cases where it had even more obvious features. In that, because of low cellularity and very few follicle-like structures, we were struggling hard to call it metastatic papillary carcinoma. Whereas here, lots of these samoma bodies, numerous samoma bodies, and there is a cluster of cell. There is a cellular swirl, which is said to be one of the characteristic features of papillary thyroid carcinoma on FNA, but that feature is reflected even in our FNA, even in our fluid smear. So that is a rare case, in fact, actually. So it is possible, just by morphological features itself, it is possible to pinpoint the diagnosis. Though in the previous case, the swirls and the presence of these samoma bodies are indicating that, and subsequently this was proven to be a case of papillary thyroid carcinoma. Further workup. Case 5, 40-year-old man who presented with epigastric mass. Ascitic fluid sample was sent to us. 40-year man, epigastric mass, and ascitic fluid sample. So clinically itself, just by history possibilities we can think of. This looks as if it is from the stomach only. Let us see what it is. Here we are seeing cellular smears, and the background is full of mucin, and there are many dispersed cells. Many of them show obvious signature cell morphology. Some are, because they are trapped within the mucin, they are forming tiny groups, otherwise usually they get dispersed only. And this is the cell block showing this extracellular mucin as well as these malignant cells. So correlating with the history, it has to be gastric adenocarcinoma. Gastric adenocarcinoma is one tumor when it presents with ascitic fluid, ascites, the cells will be totally dispersed, like we are seeing here. And sometimes you may get mucinous component also. Sometimes it may be patchy, but somehow in this particular case, it is quite abundant. And this has been demonstrated even by the cell block. So this was a case of diffuse gastric adenocarcinoma. If it is intestinal type, then it will not present like this. That will have more, it will mimic any other the adenocarcinoma from any other site, in fact, actually. Only when it is diffuse gastric adenocarcinoma, it is possible, in correlation with the clinical details, to say that this is gastric primary. So this is another gastric primary. One more example. Morphology is slightly different. It is almost mimicking a lymphoma, in fact, actually. Sheet-like pattern, but no lymphoglandular bodies. But as I said, you should look at the individual cellular features. Most of the cells may be mimicking somewhat hematolymph-like cells, in fact, actually. But these are the cells which are giving clues, in fact, actually. Giving clues. This and CK7 was done, which is positive. CK7. So this was also, this is what I said. There are certain tumors which will present like dispersed cells, a sheet-like pattern. This is one such tumor. Case number 6, a 76-year-old woman who presented with dyspnea and anorexia for 15 days, abdominal distension for 15 days, mass in the right umbilical region, and cervix and uterus were normal. Ultrasound examination revealed secondaries in liver and there was free fluid present. Bilateral adnexal, there were bilateral adnexal masses which were found to be both cystic and solid, along with omental nodules. Here also it is quite clear cut actually. It looks like as if we are dealing with a ovarian female genital tract malignancy, probably ovarian, uterus and all normal, only adnexal with omental deposits. It's quite clear cut in fact actually. So what we are seeing is papillary fragments, in fact tissue fragments. It's not that common to get these papillary tissue fragments in the ascitic fluid, but this was an advanced case showing all these papillary fragments and clusters with obvious features of malignancy, with all the features of malignancy, and you can see this papilla with the fibrovascular core, and this is one of the tumor that commonly tends to present with papillary pattern. Ovarian serous carcinoma tends to present with the papillary architecture. So this was a case of papillary serous carcinoma. Serous carcinoma. This is another case. In the previous case, we did not encounter any, though it was so cellular and there were many tissue fragments, we did not encounter any samoma body. Whereas in this particular case, there were good number of samoma bodies also. As I had shown you a case where there was ciliary tuft. This is ovarian serous carcinoma, which had occasional malignant cells with this kind of ciliary tufts. Whereas the case which I showed had almost all cells were looking had ciliary tufts in that case, but we were able to see some occasional cells, and it is classically positive for WT1 and CA125. As you know, it's one of the frequent cause of ascites, and the pleural effusion is less common, but if it presents with pleural effusion, it is upstaged. It's more advanced in fact actually, and these are the markers generally used, which can be used on fluids specimens also, and WT1 is said to be more specific, but you have to be very sure that these malignant cells, these are obviously malignant cells only, and paxate and serous origin. You can, the P53 for high grade nature of the tumor. So this is already I have shown this case. I don't think I need to. This is that case which had this mesothelial-like pattern with almost all cells having this ciliary tuft. Whereas in our previous case, occasional cells only were showing that ciliary tuft. Number 7. I have not mentioned the age of this patient. This patient was suspected with ovarian cancer, and at laparotomy, peritoneal cavity was filled with thick mucinous and hemorrhagic material, and there were multiple omental deposits also. This patient underwent appendicectomy with uh, abdominal hysterectomy with bilateral salpingo-oophorectomy. This material was not aspirated and sent, but the material was collected. This fluid was collected at laparotomy. And grossly itself, it was gelatinous. The material was gelatinous, and with using this gelatinous material, we made the smears. And this was the picture. It was not a very cellular, though it was, but it looked very thick and gelatinous. Cellular component was less. I have taken only the selected some cellular areas and taken. And cells are also not highly pleomorphic. But if you take the contour and all, they look malignant in fact actually. Only by architectural pattern you can say that the smooth contour, it's a three-dimensional cluster with smooth contour. Just by architectural pattern you can say, but otherwise morphologically they look, anyway crowding and other features are also there, and thick mucinous material, looking like a glandular structure here. These are the only clusters which I had seen. Sometimes we will not even get in this condition in fact actually. What was this I was seeing at that time for the first time in fact actually. These are all abrasing capillaries. Abrasing capillaries, almost like the chicken white like capillaries. And what is your diagnosis? So there is so much of thick mucinous material, and even the ascites itself was described as hemorrhagic and mucinous ascites. So this is obvious case of pseudomyxoma peritoneae. And this one feature, even in histological sections, you can see the proliferating capillaries. Proliferating capillaries is one of the striking features seen in cases of pseudomyxoma peritoneae. The histology of the primary tumor, appendix, the low-grade adenocarcinoma. This is the serosal surface involved by the mucinous deposits. So, pseudomyxoma peritoneae is a neoplastic condition characterized by relentless accumulation of grossly evident mucinous tumor deposits in the peritoneal cavity. And almost always it is said to be due to low-grade appendiceal adenocarcinoma, unless proven otherwise. Unless the other, if you are able to trace some other site, it has to be the it has to be from the appendix. Certain genes are known to be involved in oncogenesis of pseudomyxoma peritoneae, and it can be classified histologically. It can be classified into 3 grades, in fact, actually, and that carries prognostic significance as well. And cytologically, you may not be able to. Maybe it is possible. You can comment about low grade when the nuclear features are not so pleomorphic, whereas obviously malignant. But the grade 1, 2, 3. Histologically, it can be classified into grade 1, 2, 3. That is not possible on cytology. And the lesions are the lesions that are commonly associated with PMP, pseudomyxoma peritoneae, are the disseminated peritoneal adenomycinosis, earlier considered to be a benign lesion, but it is low grade. Then peritoneal carcinomas, mucinous system. These are less common actually. This appendiceal low-grade adenocarcinoma is the most common thing. What I have mentioned here are the rare classes: mucinous adenocarcinoma and mucinous cyst adenocarcinoma. And other primary sites can also primary malignancies from colon, rectum, stomach, gallbladder, bile ducts, small intestine. Many more sites, urinary bladder, lung, breast, have also been reported to present with pseudomyxoma peritoneae. This is one of our cases of colonic adenocarcinoma that presented with pseudomyxoma peritoneae. Unlike the appendiceal adenocarcinoma, the malignant features are very obvious in this. So this has to be a high-grade kind of tumor. Case number 8, 23-year-old nulliparous woman presented with abdominal distension for 1 month, and examination revealed a mass of 20 weeks size, and there was a nodule in the pouch of Douglas. Staging laparotomy was done, and it was diagnosed as a malignant ovarian tumor, and ascitic tap was sent for the examination, and it was hemorrhagic fluid. Let us see what is there in it. See, this was also not very cellular. However, there are these very tightly cohesive clusters of papillary clusters of cells with smooth contour. So this cannot be benign at all. But the age of the patient she is just 23 years. We need to look at that presentation also. And again, there is a papillary cluster, some gland-like arrangement also in places you can see, but somehow there's a peculiar papillary architecture there. And like there were these kind of globular clusters with many of these cells showing eccentrically placed nucleus and vacuolated cytoplasm, looking like an adenocarcinoma. But what was striking was, even in the previous, carefully if you observe, it may be difficult, but those features are better appreciated here. You can see this. The cytoplasm is bubbly. It's sometimes when cells get degenerated, they can look like this. But you need to, if it's a degenerated cell, both nuclei as well as cytoplasm will show the degenerative vacuoles. But here, it's only the cytoplasm that is showing nuclear. This is one of the feature of a yolk sac tumor. And whenever you encounter clusters of malignant cells that mimic adenocarcinoma in a young female patient, you need to be very careful, in fact, actually, because serous carcinoma is not that common in the young age group. Those malignancies are more common in the elderly age group, in fact, actually. So you need to be, surface epithelial tumors are more common in the elderly age group. So whenever you see cases mimicking adenocarcinoma, first thing you need to rule out is the possibility of yolk sac tumor. And there are certain clues. What are those certain clues? The bubbly cytoplasm, one thing. And sometimes, if you are lucky, you may get some extracellular hyaline material or intracytoplasmic hyaline globules. You may get that, but it may not be possible to see in this was a case of yolk sac tumor and subsequent, but anyway, we had not picked it up as yolk sac tumor. We had called it adenocarcinoma only. But this is the lesson which we learned. Whenever we report these kind of clusters, we need to be very careful. In a young woman, we need to be very careful. That is the lesson we learned from this case. And histopathology showed it to be a case of yolk sac tumor. So PS positive, take this hyaline globules and the Schiller bodies. Few more examples. This is on FNAC. What I wanted to highlight is the cellular details. See here, even the nuclei have some cytoplasmic vacuoles, and that's the nuclei have some vacuoles. So this look like degenerative vacuoles. It may be degenerative vacuole also. Maybe it is slightly degenerated. But here you see, this is an FNA material, similar morphological features, what I showed in the previous case and what I am showing in the present case. Even in FNA material, these cells with finely vacuolated, bubbly kind of cytoplasm you can see, in fact, actually, and the extracellular hyaline material. Sometimes you can get them in the fluid cytology smears also, but rare. Finding these kind of tumors in the fluid itself is rare, in fact, actually. So AFP, I have not marked it, AFP positivity. This is what I wanted to show. See, this is a neoplastic cell from a yolk sac tumor. It shows only the nuclear vacuoles, but the nucleus looks, cytoplasmic vacuoles, which shows only the cytoplasmic vacuoles, whereas the nuclei looks clear. It doesn't have any vacuoles, in fact. So it is not degenerative. It is a cytomorphological clue for yolk sac tumor. Case number 9. She was a 25-year-old patient presented with abdominal distension for 8 months. Examination showed cystic ovarian mass of 24 week size, and uterus was normal. A mass was felt in the anterior and right fornix. Clinical diagnosis was malignant ovarian tumor. Ascitic tap, we got some yellowish ascitic fluid. This is the picture we saw in fact actually. Not a very cellular smear, some clusters I have shown here. They almost look like, you can mistake them for some mesothelial cells also. Maybe some window-like thing is also there. But the nuclear features are looking different. It is somewhat evenly distributed and granular kind of chromatin. Granular and irregular, little bit of irregular contour, which is more pronounced here in fact actually, more pronounced here. And what is more important is these kind of tubular structures, which can be interpreted as glands in fact actually, like these kind of tubular structures. This is what is peculiar. Some almost convoluted kind of the clean kind of nuclei also, but no proper grooving or anything like that. But this is a young female patient. They are not proper mesothelial cells, and we need to, these are tubular structures which need to be remembered in fact actually. This is a very rare case of granulosa cell, juvenile granulosa cell tumor, not adult one. Adult one will have classic features in fact actually. Rounded nuclei, granular chromatin, and the coffee bean nucleus. The typical coffee bean nucleus with grooving and all you will see, but here it is not there in fact actually. Only the tubular structures are. At least you can suggest the possibility of, we did not call it juvenile granulosa cell tumor because it was difficult for us. But I am just telling you that these kind of clues, especially when you are coming across such cases in an unusual clinical, with unusual clinical presentation, you need to, because age is again not fitting the surface epithelial tumor. So you can suggest the possibility, or if you have the suspicion, then you can get the markers done. What markers you can get done? These tumors can be positive for calretinin also, but better to avoid calretinin. Instead, you use inhibin. So we did not use it. It was suspicious for adenocarcinoma. It was reported as suspicious of adenocarcinoma, but it was not actually. It turned out to be a case of juvenile granulosa cell tumor. The clinical approach is very important actually. You need to look at the clinical presentation, young patient, and morphology is not matching with the surface epithelial tumor also. It doesn't look like mesothelial cells also. Then what other possibilities? What are those clues, morphological clues that is suggesting the possibility of juvenile granulosa cell tumor? The tubular structures and the nuclear changes in fact actually. Some irregular, convoluted kind of the indented kind of nuclei. These are important in fact actually. It can mimic adenocarcinoma. The tubular structures, nuclear indentations, absence of calyx nerve bodies, and coffee bean nuclei will indicate that this could be a juvenile granulosa cell tumor. I have seen a case of adult granulosa cell tumor, but that is easier in fact actually. You will get those calyx nerve bodies and you can easily identify them, and inhibin is a preferred marker. Case number 10, a 55-year-old postmenopausal woman who presented with abdominal distension, vaginal bleeding, and pelvic pain for 1 month. On examination, she had ascites and a mass of 20 peak size. Uterus was bulky. Hemorrhagic fluid, 10 ml of hemorrhagic fluid we received, and TH with BSO was done. This was the cytology which we received before surgery, and very cellular. What is striking is, if you see this, all these cells are looking smaller, looking like some inflammatory cells. Even this dense aggregate here, it looks like a dense aggregate. That also looks like an aggregate of inflammatory cells. Only under higher magnification, they are looking somewhat different in fact, somewhat different, and there seem to be some calcific structure here. And of course, in this lower magnification picture itself, you can see some pale, some relatively pale looking cells in fact actually. They look like this, but they look atypical. though they look somewhat pale, they look atypical. That atypia is obvious in this, in fact, actually. It's a cluster of cells, three-dimensional cluster of cell. Again, the features of malignancy are there. What are those features? There is pleomorphism, there is high NC ratio, there is post-chromatin, there is so much of nuclear crowding here, in fact, cellular and nuclear crowding, and the contour of this cluster is smooth. Contour of this cluster is smooth. So this is epithelial. There is no doubt about this part, in fact, actually. But what are these cells? What are these cells? They look different. They are not inflammatory cells. They are not, usually your histiocytes and all will not aggregate like this. And there seem to be some calcific-like material. I'm not very sure. Calcific-like material. So let us see now the PAP stain smear. See, PAP highlights it so well as compared to your MGG stain smear. These are all the stromal cells. The ovoid to elongated and even some spindly type of cells you can see. These are inflammatory cells here. So there are stromal elements, there are these epithelial elements with glandular architecture. So there are two, and she is an elderly female. The possibility, what are the possibilities? There is a possibility of mixed malignant tumor, malignant Mullerian tumor. This was a case of malignant mixed Mullerian. Most of these cases, many of these malignant mixed Mullerian tumors tend to, when they present with ascites, they tend to present only with the epithelial component, and most of the time it will be reported as metastatic adenocarcinoma. But in this case, we were able to pick up even the stromal element, which was also looking atypical. This was the histology of that. The epithelial as well as the stromal elements, even the cartilaginous heterologous elements are also there. As we know, it's a biphasic tumor that carries very poor prognosis. And as I said, incidence of positive cytology is also very low. And patients with lymph node and ovarian metastasis are likely to have high percentage of positive cytology. And a positive cytology generally correlates well with the depth of invasion also. Case number 11. This was a 55-year female. She was a known case of carcinoma cervix, and we had ascitic fluid for cytological examination. And as this was a known case of carcinoma cervix, that you should remember. And this is what we were seeing in fact. It's a cellular smear. There are numerous abnormal cells, both discrete as well as loosely cohesive as well as tightly cohesive clusters. And many of these cells show even cytoplasmic vacuoles. And most of these clusters show rounded contour only. And cytoplasmic vacuole on this thing. And there are some individual malignant cells also. But it's a known case of squamous cell carcinoma, cervix, but showing features of adenocarcinoma here. These features are features of adenocarcinoma. And look at this. Some, you may mistake it for some mesothelial cells also, but they are also atypical cells. But these are definitely, these resemble mesothelial cells again. And we did markers. P63 was also done because it was a known case of carcinoma, squamous cell carcinoma. P63 was also done, and we did EMA. So EMA in our scenario, it works out very well. In fact, it serves as a very good epithelial marker. Though at international level, this will not be considered as a very good epithelial marker, where the incidence of mesothelioma is more. P63 was negative. That means there was no squamous cell component. Actually, this is what I have seen. At least a few cases that have been diagnosed as squamous cell carcinoma, adenosquamous cell carcinoma, will be presenting only with adenocarcinoma component, not with the squamous cell carcinoma component. But of course, squamous cell carcinoma component sometimes can come in ascitic fluid as well. So it's less common. The effusion with cervical cancer is less common, and SCC cells appearing in serous fluids is somewhat rare, and if SCC cells are present in the serous body fluids, if they are keratinized, it's well different. Keratinized the SCC or well differentiated SCC, it becomes easier. When it is non-keratinized SCC or poorly differentiated SCC, it becomes difficult to pick up squamous cell carcinoma and serous body fluid cytology. This is a case of squamous cell carcinoma, the actual squamous cell carcinoma, which was demonstrated even by the P63 immunostain. You can see even the evidence of keratinization. That itself is enough, but it was demonstrated even by the P63 immunostain. Coming to the case number 12, this was a pleural fluid sample received from an elderly female. I have taken this slide from one of my colleagues, Dr. Sajini Jakavan. She couldn't write this paper, whatever it is actually. This is the sample we got, in fact, actually, and the pleural fluid sample was showing this matrix material, which was looking that magenta matrix material, looking chondrite, and you can see these cells entrapped within the matrix. Some cells, you can see this, you can see, and the cellular also. Cellular for chondrite, this thing. This is a cluster of mesothelial cells. Had there been one Pap stain smear, it would have been nice to show you the cellular details, but I am not able to. But you can see these cells. There are quite a few cells. So, naturally, it has to be a chondrosarcoma because these are all sites entrapped within the cartilaginous matrix. Diagnosis is not very difficult here because there is no other differential diagnosis with this kind of morphology. See, look at this. Cellular details are, you can see this trinucleated cell, binucleated cell, mononuclear cells, chondrocytes, all these malignant chondrocytes trapped within and this is all chondrite matrix. So it's a metastatic, it's very unusual because I don't think anybody has reported a case of chondrosarcoma in serous body fluids. This is supposed to be the first case, but not yet documented. Metastatic chondrosarcoma. Subsequently, we received even the pleural biopsy, and this was the chondrosarcoma arising from the rib, in fact. The case number 13. This is a 21-year male patient who presented with abdominal pain for 2 months, and the CCT showed well-defined lobulated lesion in the right thoracolumbar spinal region and right hilar lymphadenopathy. And the outside biopsy, it was reported as desmoplastic small round cell tumor. This was the pleural fluid cytology. It came to me, and it came with that outside diagnosis. It had already been diagnosed elsewhere as desmoplastic small round cell tumor. So we have to start with that only when it comes to us. So it looks like a small round cell tumor. This was the diagnosis. It looks like a small round cell tumor, but to say that this is a desmoplastic small round cell tumor, it is very difficult. We can call it small round cell tumor, but what features were there actually in this? There are these cells showing cytoplasmic vacuoles. Even individual cells you can see. The cytoplasmic vacuoles are there, in fact, actually. These kind of vacuoles, we need to think of small round cell tumors that can manifest with the cytoplasmic vacuoles. And we need to do some conventional, the histochemical stains also, to know whether it is glycogen or not, in fact, actually. And material was insufficient. We were not able to do everything, in fact, actually. And subsequent materials, we had to do whatever we wanted to do with the material we had, in fact, actually. Of course, cell block was made, and differential diagnosis for these small round cell tumors that manifest with cytoplasmic vacuoles. PNET is one thing. You can have glycogen vacuoles in that, in fact, actually. And the skeletal muscle tumors, embryonal rhabdomyosarcoma can also have, but outside diagnosis was desmoplastic small round cell tumor, in fact, actually. And even in young patient, so the other possibility, can this be some germ cell tumor? Germ cell tumor will not look so small and they will not look so compact, because seminomas can have glycogen vacuoles. But anyway, this was not looking like that, in fact, actually. This was not looking like that. We were thinking of all those lesions that can present. This is not the morphological feature of any germ cell tumor, in fact. Actually. It looks like a small round cell tumor with glycogen vacuoles. Subsequently, we did we made the cell block, and on that, desmin was done. And subsequently, this we received in bone marrow biopsy. Bone marrow also showed infiltration by these cells, and on bone marrow, myodivin was done, and that was also positive, in fact, actually looking like a rhabdomyosarcoma case. Let us see. And see, this is it was done on the bone marrow. Myodivin, and this is myodivin and desmin. And this patient had even pleural biopsy, and the patient also had breast nodule. Even those were sampled. Those also showed infiltration by these small round cells, malignant small round cells, which were positive for this thing. So this was a case of this was not a case of desmoplastic small round cell tumor, but this was a case of embryonal rhabdomyosarcoma, which was positive for myodivin as well as desmin. Sarcomas metastasizing to serous body cavity is very rare, in fact, actually. And the sarcomas that have been documented with metastasis to serous body cavities include angiosarcoma, liposarcoma, synovial and epithelioid sarcoma. Rhabdomyosarcoma is reported, osteosarcoma, and chondrosarcoma. This is not documented. So we have seen one case, and so I just wanted to show some malignancies other than epithelial tumors. Then let us come to the hematolymphoid malignancies. Somewhat these are more frequent. More frequently they involve the serous body cavities, and virtually any kind of hematolymphoid malignancy can affect the serous body cavities. It can be acute and chronic leukemias, both Hodgkin's and non-Hodgkin's lymphomas. Myelomas can involve. So we need to have proper clinical correlation with clinical hematological findings, clinico-radiological findings, and we need to depend on certain hematolymphoid neoplasms are easy to diagnose, in fact, actually, in fluid cytology also. Whereas certain hematolymphoid malignancies may be difficult, in fact, actually, especially when we in an elderly patient who presents with lymphocyte-rich effusion, and the lymphoid cells are looking like mature lymphocytes, then it becomes difficult to distinguish it from just plain lymphocytosis with CLL varicella. It becomes difficult, in fact, actually. So this is a case of a 27-year-old male who presented with breathlessness and exhaustion for 2 weeks, and he had both leg and abdominal swellings for 12 days, edema and ascites, fever for 2 days, and X-ray and echo showed massive pericardial effusion. This was the main presentation, actually. And the pericardial fluid was, no other investigation had been done, in fact, actually. This was sent to us for examination, and it was showing, I have put this actually, but you must have heard the diagnosis also. Patient had presented with pericardial effusion, massive pericardial effusion, in fact, actually. So these cells are looking somewhat small lymphoid only. Small lymphoid looking almost like mature lymphocytes only. These are some mesothelial cells. This is one mesothelial cell here. These are lymphoid cells, monomorphic, looking monomorphic. Here it looks, in this smear it looks medium-sized with evenly distributed somewhat coarser chromatin and some conspicuous nucleolus. So they are atypical lymphoid cells. It was reported as atypical lymphoid cells, and subsequently clinical hematological workup was also done, and I think on bone marrow it was shown to be these atypical lymphoid cells were shown to be positive for, they showed block positivity and also CD3 positive, indicating that it's a T-cell leukemia or lymphoma. And it was a case of T-cell leukemia or lymphoma that manifested as a pericardial tamponade. And subsequently, this patient had a rapid downhill course and expired on 5th day of admission. As I said, it is often difficult to interpret lymphoid rich effusions. You need to go back to the clinical details. If you are seeing these kind of lymphocyte rich effusion in a young patient, then it is okay. If you are seeing this kind of picture in an elderly patient, it is always better to rule out a possibility of CLL or SLL. So it is better to get the clinico-hematological details as well. And even the examination of lymph nodes and all that thing need to be done. This is another case where it is showing a bit polymorphous kind of population, but some cells are looking atypical. Then also you will have problem. In fact, actually, what we can do at this stage is we can do some basic immunomarkers, T-cell marker, B-cell marker. So to decide whether we are dealing with a polyclonal population of cells or monoclonal population of cells. But again, it becomes, if it is monoclonal kind of, if it is positive for CD3, then also it becomes difficult. Then also, if it is positive only for B cells, it may be easier. In fact, actually, it's always better to have clinico-hematological correlation in these cases. This I have already discussed. So, what is the role of routine and special stains in dealing with lymphocyte-rich effusions? So, most labs we use Romanowski stains, one of these Romanowski stains, and Pap stains. Yes, much information can be get from this. In fact, actually, adequate information. But of these, which smear is better when we are dealing with hematolymphoid neoplasms? Usually, Romanowski stains gives more information. However, PAP also is useful if you are dealing with a case of follicular lymphomas, which can pick up the cleaved cells better. And basic immunomarkers we can do, like T and B cell marker. Depending on the morphological features, you will have to decide. And of course, you can go for flow cytometric evaluation also in case of lymphocyte-rich effusion. This is another case, 3-year-old male who presented with fever and breathlessness for 1 week, abdominal distension for 1 week. On examination, there was moderate hepatomegaly, and the patient had even enlarged left cervical and axillary lymph nodes. Right-sided pleural effusion was there, and left axillary lymph nodes were also there with her actually. And both pleural and ascitic fluid samples were sent to us. So this is, I have taken from the published paper only. This was recently published. I could have taken the fresh picture itself. See, it's a polymorphous population of cells. What I discussed so far was monotonous population of lymphocyte-rich effusion. But here it is polymorphous population of cells. But you don't have suspicion of reactive kind of picture, because there are very huge abnormal cells. In fact, actually, large numbers of these abnormal looking cells having abnormal nuclear features like nuclear folding, lobulation, and all that thing. In fact, actually, there is a cell which seems to have a fitiform appearance of nucleus, fitiform nucleus. So somehow when we get this kind of picture, two things come to our mind: Hodgkin's and non-Hodgkin's. Hodgkin's very unlikely to present like that. In fact, actually, you will never. Hodgkin's is one tumor where you have to hunt for RS cells. It won't be so obvious like this, but here it is very frequent. There are some RS-like cells also, but more than RS-like cells, very pleomorphic looking cells, lobulated, cleaved kind of things and all that thing in fact actually, and fetiform nuclei. Of course, diagnosis you'll have to suspect in fact actually. We have done CD30 which is nicely positive. We also have done the ALK1 that is also positive. This is the histology of the cervical lymph node, and the same markers have been done on the histological section also, proving that this is a case of anaplastic large cell lymphoma. So you can diagnose melanoma. This is also one of the cases which we picked up by initial cytological examination only, and subsequent work proved it to be a case of myeloma. But myeloma diagnosis was picked up by cytological examination because morphologically they can easily be picked up in fact actually, especially the differentiated plasma cells if they are there. I think this is the last case. 25-year female patient who presented with pericardial effusion, and the cause of effusion was not known in fact actually. This was the smear we received in fact actually. It's full of these inflammatory cells, more macrophages, and these monocytide cells having monocytide nucleus, and some neutrophils, scattered neutrophils. Maybe there are occasional lymphocytes also, but more of macrophages. And many of these macrophages have engulfed this homogenized material, homogenized pink material. So these are all Ellis cells in fact. It's totally homogenized. You need to differentiate it from Tart cell. In a Tart cell, it will not be homogenized in fact actually. Still you will be able to appreciate the chromatin pattern where you cannot see. Here there are two monocytes which are trying to engulf. They are fighting for this. It's a very interesting thing in fact actually. Two cells already has engulfed one, but it's trying to engulf another one in fact actually. So these are all, and you can get whenever you get like nice ones in fact actually, even in this so many of them. This is one benign case I wanted to share with you. These are all Ellie bodies and these are Ellie cells. So further workup in this case showed a high titers of anti-nuclear antibodies, and it also showed anti-double-stranded DNA antibodies. So this was proven to be a case of SLE. So it's not always possible to pick up this thing. If it is like this, it becomes easy to pick up Ellie cells. But sometimes when you get smears with necrotic neutrophils in a young patient with unexpected cause of effusion, when the cause of effusion is not predictable. In those cases, you need to be, when the cause of effusion is not very clear and the patient is young, especially if she is female, you should have a high index of suspicion and look for that, because every time it will not be so as obvious as in this particular case. Sometimes it may be, you may have to hunt for them, and if you are able to pick up some Ellie cells, you'll be giving them the diagnosis just by cytological examination itself. So message in this case is that Ellie cells in serous body fluids are a rare finding, but when present are highly specific for SLE. And though it is more common in pleural fluid than the pericardial and peritoneal fluids, in this case we have encountered it in pericardial fluid, and rarely it has been reported in synovial fluids as well actually. And the clinicians as well as pathology should have a high index of suspicion of SLE in any young patient, any young woman presenting with an unexpected serous effusion. So I have completed all my cases. So to conclude, there are certain obvious and subtle cytomorphological and cytoarchitectural clues which, in correlation with very basic information such as age, sex and site of effusion, often effectively assist in identification of the possible or precise either possible or precise primary site of malignancy. That is one thing. And immunomarkers are of great help in cases with unknown primary or morphologic ambiguity in deciding the primary site. Actually. And involvement of serous cavities by hematolymphoid neoplasms is relatively frequent, while sarcomas metastasizing to body cavities are rare. In patients with hematolymphoid neoplasms, a careful morphologic assessment with relevant clinical details and appropriate ancillary tests often provide accurate diagnosis at initial presentation itself. Of sarcomas, well-differentiated tumors are relatively easily detectable, while cases like metastatic small round cell tumors need further workup to arrive at right diagnosis. Thank you so much for your patience.
So thank you, Dr. Siddaraju. One exhaustive but so interesting. In fact, I was watching that it is now nearly 2 hours. We have discussed, and in fact, we have not lost. We wanted to learn more. Excellent presentation. And what you have not covered, you have covered so many types of tumors, so many beautiful slides. Where should I start? There is carcinoma, there is sarcoma, there are hematolymphoid aspect, and it ends with your that benign that Ellie cell. In fact, in my library, there is one very old book, and in that book, when I used to start to my PG teaching, then I searched for that history of Ellie cell, and to start, it was first isolated in the synovial fluid. It was first isolated, synovial fluid, and this is really marvelous that when we think of Ellie cell, we always think of the blood, but you have nicely found it in your pericardial fluid as well. This is excellent case, and your that diffuse single cell type mesothelioma type cells. In fact, I am dead sure that PGTs and as well as practicing pathologists from your this particular slide, they will be more careful about sending them to find out some mesothelial proliferation, because they will do all the IHC and other things. Your papillary carcinoma in pericardial fluid, another marvelous. Chicken wire capillary in pseudomyxoma peritoneae, this is really picturesque. Your yes, and you're starting from desmoplastic small round cell tumor and ending with that embryonal rhabdomyosarcoma, another very good teaching learning material for the PGTs as well, because they will never forget it, I think. And at the end, in fact, today I just find out one fluid, and I used to do it, that they have simply asked for malignant cell or not in fluid. So I write it down, no malignant in bracket, non-lymphoid. Non-lymphoid. In fact, I was just validating that part as well. Yes, I think we used to lose so many lymphoid malignancy in our routine practice because we do not give them importance. Actually, we do not give them importance so much. Whenever we find lymphocyte, lymphoid cells, okay, forget it, this can occur. But from your presentation now, these things will be very much emphasized. Practicing pathologists as well as the PGTs, they will definitely learn that give more emphasis on the clinical and other. And in fact, I was then thinking of that applications of flow cytometer, and you already told that part as well. So as a whole, this is one complete composite and very good deliberation. Thank you so much. Thank you.
Thank you, sir. Thank you so much. Thank you, sir.
Wish you all the best. Stay safe and healthy.
Okay. Thank you so much, sir. Thank you so much.
Thank you so much. And Dr. Nadeem, thank you so much for your this effort to encourage to make the PG teaching more enriched, and obviously this is more expected from man like you. the one important pathologist of Kolkata. Thank you so much, Nadim. Anything to anything from your end, please?
Thank you so much, sir. The honor is all mine. We have two very eminent cytopathologists here. Thank you so much, Dr. Bidut Goswami, sir. And thank you so much, Dr. Siddaraju, sir, for coming
Thank
to
you,
this
sir. Thank you.
platform and sharing. It was a wonderful presentation. Although in between we had some internet problem because the cyclone was going up across Kolkata, but I think we have been able to manage everything. Thank
Okay,
you so
sir.
much,
Thank
sir.
you.
Take care.
Thank you so much for sir, your invitation.
Right.
Okay, sir.
Good night.
Thank you, sir.
Take care. Bye. Thank you.
Okay, sir.
But Nadim, I was thinking that I was afraid of my neck bite, but I was very continuously I was getting.
Yeah,
Thank you
I
so
know.
much.
That's
Thank you.
good. Thank you, sir. Take care. Bye bye. Thank you. Bye.
So we can leave.
Yes, sir. Requesting Siddaraju, sir. Sir, please share the. Sir, please share the PDF of the presentation. We will forward it to all the students.
Okay, sir. I'll do that, sir. I'll do
Thank you,
that,
sir.
sir.
Take care. Thank you. Bye bye.
Okay.
Bye.
I can close this now. Can you leave now? Prabha is there. Hello, Prabha. Where should I? This.
Nadim, anything to? We can leave. I think so.